On behalf of organizing committee, I invite Professor Anuradha Madam. She is one of the senior most chiefs in ICH, and she is taking care of the genetic department in ICH, and at present she is also dealing with many rare LSDs. And today she will be talking about how to approach a genetic disease for half an hour. Followed by, there will be a 30 minutes cultural program by the UGs. That is for our mind relaxation. Then followed by, you have a capsules of 3 important sessions, newer microbes, approach to IAM. Then you will have a 10-15 slides will be projected from the pathology, where team will be asked to answer. Then followed by our keypad session. I already announced that in keypad session, kindly sit now itself 2 people so that one key 2 persons can use. So the keys are arranged in such a way that every alternate chair has got a key. So you can sit in such a way that 2 persons can operate the key when the keypad session comes. Now I invite Madam Anuradha Madam for lecture on approach to genetic disorders.
A very good evening to one and all. At the outset, I would first like to thank our registrar for giving me this opportunity to talk about this genetic disorders in this ICT session. So this title, I feel that most of the pediatric disorders are having a genetic basis. So I think a genetic approach to pediatric disorders will be a better way of dealing with this session. So most of the medical problems associated with genetic disorders can appear at any age. But identifying a genetic cause ultimately aids in medical decision regarding the prognosis, recurrence risk, management, and counseling of these patients. So the whole, my lecture I dedicate to ICH and the pediatric children of this hospital. So we deal initially in our OPDs, we see so many different varieties of pediatric patients. That is, some are tall, some are short, some come for ordinary medical ailments, some come for some debilitating illnesses. They have different features, dysmorphism, or skeletal abnormalities. But the basis for all these disorders is only one, that is the cell, which that is the nucleus, which contains the DNA, which is the control panel for all the different types of phenotypes. So all of us begin with the cell and its surrounding structures in the cytoplasm, like the mitochondria, Golgi apparatus, etc. So what is the human genome? So the cell being the basis, ultimately all of us are only made up of amino acids and proteins. So these proteins, the various mechanisms by which these proteins are provided by the DNA through the processes of transcription, translation, then post-translational modifications, results in the formation of different proteins which are controlled by this DNA in the chromosomes. These cells together form the tissues, and the tissues together form the organs, the systems, and finally the human body. So basically, it is the protein, and we are controlled by the DNA, which is actually the gene, a part of the DNA which encodes for the particular protein. So like any approach to any child in pediatric, a good history is really very, very important. Here you give, when you go into the genetic aspect, you have to give more importance to the family history. So this is the family history. Ideally, it's better you take a history for at least 3 generations. So if you are not able to get a good history with one sitting, ask them to come frequently and you get a good pedigree, which is really forms the basis of your genetic analysis further. And when you go into the family history, give importance to any previous neonatal deaths, recurrent abortions, or any stillbirths, history of consanguinity. All this should be given importance in your pedigree analysis. So these are the various symbols you use. This is a male, this is a female, and this shows the siblings. Once you take a family history, you have to go into a detailed physical examination. So from head to foot, apart from a routine, there are some markers which help you to say that it can be a genetic disorder. So what are them? Can you name? Can you name some findings in your general examination? So from head to foot, when you examine, there can be a microcephaly, abnormal shapes of the head. So something suggestive of a craniostenosis can be associated with some syndromes like upper cruisens. Then when you come into the face, look for any dysmorphism in the face, cataracts, hypertelorism, exophthalmos, low set ears, abnormality in shape of the nose. All these can be seen in the face. Then when you come to the neck, short neck or a webbing of the neck, short stature, any bony abnormalities in the chest, kyphoscoliosis. Then you go down, again, any ambiguity in the genitals. So in a newborn, suppose there is an ambiguity, what do you think of? There is a clitoromegaly, CAH. So any ambiguity at birth, then again your extremities, short limbs, polydactyly, syndactyly. So all these things can give you a clue saying there is something beyond the normal. There should be something we have to go into detail. So a good clinical examination with anthropometry. Give importance to anthropometry because it is very important in your skeletal disorders. And moreover, there are even special growth charts. For example, for Down syndrome, there are special growth charts which you have to look into instead of using the normal growth chart. So once you have come to the clinical diagnosis, you have to finally evaluate and see which type of genetic disorder that particular features are fitting into it. So what are the broadly these genetic disorders can be classified into chromosomal, which is the most common, then the Mendelian disorder or single gene disorder, which is becoming common because of the advanced technology. We are able to diagnose more cases, and non-Mendelian causes like mitochondrial, replete genomic imprinting, uniparental disomy, mosaicism, and multifactorial. So first we will go into the chromosomal disorders. So chromosomal disorders mean, what do you mean by chromosomal disorders? Any abnormality occurring in the structure or number of the chromosomes. Okay, so it is otherwise called as aneuploidies. So whenever there is a numerical abnormality, there are two types. That is, the whole set of chromosomes can duplicate or triplicate. That is called as polyploidy. Usually we do not see any child with polyploidy because they get aborted. Then the next common is your somies, that is monosomy or a trisomy, when only particular chromosome there is a duplication or a loss of the chromosome. So these, among these, depending upon where this abnormality is present, that is whether it is in the autosome or in the sex chromosome, you are able to see only two disorders in pediatric. That is, one is Downs. Okay. So this is a 1 year, 3-month-old child who came to the genetic OPD with short stature, dysmorphism, hypotonia, and developmental delay. So this child on evaluation had a mongoloid slant of eyes, depressed nasal bridge, mental retardation, hypotonia. Apart from your routine investigations, a karyotyping was done which showed what is this? This 21st chromosome is having 3. So it is a trisomy 21 suggestive of Down syndrome. Okay. So this is the most common finding you can get in a Down syndrome patient. So what is the reason for getting a trisomy 21? Can anybody tell what is the mechanism? Yeah. So a book say that any mother with an advanced maternal age, the chances of because of the aging ovum, the chances of a meiotic non-disjunction is common. So this is just to explain the meiotic non-disjunction. So meiosis, normal meiosis, there is a meiosis 1 and meiosis 2. So normally the homologous chromosomes divide into 2, and these are the chromatids, which after fertilization you get a zygote, and you get 2 chromosomes in each of the zygote. Here there is a non-disjunction in this and this. So this is occurring in meiosis 1 and this is in meiosis 2. What happens? Because of this non-disjunction, there is failure of separation. So here normal fertilization occurs because 2 has come this side and finally the zygote has 3. But here, because there is no chromosome, finally you get only 1. So there is a monosomy and this is a trisomy. So this is the effect you will get following a meiotic non-disjunction. So this, when you get an extra, can be a trisomy. When there is loss, it is a monosomy. So this is the most common abnormality occurring in Down syndrome, producing a trisomy 21. So this is a normal karyotype with your autosomes and your sex chromosome, and this is a child with Downs having a trisomy, and it's a male child. So what are the other abnormalities that can occur? So other common ones are the mosaicism and the Robertsonian translocation. So what is mosaicism? It means if you do a karyotyping, that child will have 2 different sets of chromosomes. One will be normal, the other will be having a trisomy 21. So that means they have 2 different cell lines in that same person. So this is mosaicism. The third common, which is not quite common, is the Robertsonian translocation. So what is Robertsonian translocation? That is when there is a translocation of genetic material between 2 acrocentric chromosomes. So that is when a translocation occurs between acrocentric, it is called as a Robertsonian. So what happens? So when there is a translocation, your P arm get lost because acrocentric only has a centromere and a Q arm. It doesn't have a P arm which is only a stalk. So during the translocation, the P part gets lost. There is a centric fusion, and finally you get only the 2 Q arms. So you get a single chromosome with the Q arms of both the chromosomes. So when one of the parents has this translocated chromosome, he or she becomes a carrier for it. So when this parent has a child or goes in for a fertilization, the zygote will have 3 chromosomes. Okay, already this translocated plus a normal chromosome. So the chances of having a Down syndrome child is more. And because one of the parents is a carrier, there is a recurrence risk of Downs. So this can otherwise be called as a familial Downs. So karyotyping is very important in diagnosis of a child or for further counseling in Down syndrome. So these are the 3 possibilities. Trisomy is common and these 2 are quite rare. So next, coming into the structural aberrations in chromosomes. So what do you mean by structural? The number is the same, but there are some alterations in the structure of the chromosome. So among this, you get deletion where part of it, genetic material gets deleted, and this is a duplication where you get more material, inversion or insertion or translocation. So here the chromosome number will be same. So when you do a normal karyotype, if there is a very gross abnormality, it can be picked up. Otherwise, you have to go for further genetic tests. So this is a child, a 3-year-old child who had come to the OPD with developmental delay and facial dysmorphism in the form of hypertelorism, prominent nose and ear abnormalities. She was operated for an anorectal anomaly in the neonatal period, and she had a heart disease, tetralogy of Fallot, which was confirmed by an echo. So whenever there is a child with facial dysmorphism and heart, you initially try to do a karyotyping to see if there are any chromosomal problems. So an initial karyotyping was done. It was found to be normal. So with the suspicion, a fish analysis was done. So this is a picture of a fish where they used probes for the Q11 region in the 22 region. So you see here, there are two signals. That means this chromosome 22 Q11 region is normal, but here there is only one signal, showing there is a deletion. So this is a child with 22q deletion syndrome, which cannot be picked up by a normal karyotype. So microdeletions, you have to go for further tests like FISH or MLPA. So next, going into the Mendelian disorders. So what are Mendelian disorders? They are otherwise called as single gene disorders. There is an abnormality or mutation in a particular gene resulting in a phenotype. So this is a picture showing the various chromosomes and each having some mutated gene producing a syndrome or different abnormalities. So normally we have 23 pairs. So out of this, 22 is autosome and 1 is X chromosome. So how is the representation of trait in our body? Because of the pair, it has a representation in both the chromosomes, or it is called, both the alleles should be normal for a normal representation. So whenever one of the alleles is different, you can get an abnormality. So in Mendelian disorders, depending upon the mutant gene, whether it is homozygous or heterozygous, you can get various different mode of inheritance. So first we will go into autosomal dominant. So what are the characteristics of an autosomal dominant mode of inheritance? Anybody? Yeah, there is an abnormal allele, but it is very strong enough to produce manifestations even with one abnormality. So one of the parents, the affected father with a normal mother, their offsprings. So what are the possibilities? So either one of the parents can be affected, or it can even occur sporadically due to mutation in the zygote. So what are the possibilities? So the possibilities have been derived by using some probability or mathematical calculation, and by the Punnett square technique, they have arrived saying that 50% chances of having a normal child, 50% being affected for each pregnancy, and both the sexes can be affected equally. So these are the characteristics of an autosomal dominant mode of inheritance, and the phenotype can vary because of the variable expressivity and penetration. You can get a variable mode of presentation of a single disorder. Autosomal recessive, both the parents will be carrier. So there can be or may not be a history of consanguinity. It can be or cannot be. And the chances are, for every pregnancy, 25% can be normal, 25% can be affected, and 50% will be carriers. So this is the mode of inheritance for autosomal recessive. So a few examples. So she's an 8-year-old child, first born of non-consanguineous parents, and her second child of the parents is a male normal child. This child had microcephaly, synorphis, dysplastic teeth, low hairline, hypertrichosis, with skeletal abnormalities like kyphoscoliosis, and had a cataract operated. Initially, because of the dysmorphism, karyotyping was done and it was found to be normal. So clinically, we arrived as the patient to have a Cornelia de Lange syndrome. So what is the mode of inheritance? It is an autosomal dominant disorder. So the karyotyping will be naturally normal. You have to confirm only by doing mutation analysis of the genes affected. So this is another child, a 3-year-old, second born of third degree consanguinity. She presented with developmental delay, short stature, sparse eyebrows, teeth, microcephaly, dysplastic teeth, and had a cleft lip operated with a polysyndactyly. The nails were actually normal. Echo was also normal. So clinically, we thought of a Ellis-Van Creveld or a contraectodermal dysplasia. So the mode of inheritance is autosomal recessive. So these are siblings, both are siblings. One is 12-year and one was 9-year. They were referred from Calcutta for short stature and skeletal deformities. On evaluation and on doing a skeletal survey, they were found to have Morphogenesis syndrome, which was confirmed by enzyme analysis. And this is also an autosomal recessive condition. And what will be the mode of treatment for this child? Apart from the supportive, you can plan a bone marrow or an enzyme replacement. So this is a 5-year-old male child, had a Turner's phenotype, short stature with webbing of the neck. There was anti-mongoloid slant, and echo showed a pulmonary stenosis. So karyotyping done was normal. So it was a clinically suspected Noonan's, which has to be confirmed for pathogenic variations in the PTPN11 gene. Then this is a 9-year-old child. She presented to our hospital from nearly 6 months of age, and she was attending all the departments in ICH for vomiting. And finally, metabolic disorder was suspected, and tandem mass spectrometry and a GCMS confirmed this child to suffer from urea cycle disorder, probably an arginase deficiency. So this is also an autosomal recessive mode of inheritance. This child is on regular follow-up and on special nutrition. We have to thank our registrar and professor of biochemistry for the extra care they have taken to provide special nutrition for these children. So these children are getting special nutrition from our nutrition department. So all these we had talked about autosomal dominant and recessive disorders. Now we go into X-linked dominant. So X-linked dominant, the mode of inheritance is similar to that of autosomal dominant. So common disorders are incontinentia pigmenta, and what we see commonly in ours is a child with intellectual debility, with a macroorchidism, and a male child. You suspect a Fragile X syndrome. So how do you confirm Fragile X? You have to do a triplet repeat expansion of the CGG in an FMR1 gene. So if there is a triplet repeat, it confirms to be a Fragile X syndrome. So X-linked recessive. So these are two pedigrees. The first one, the mother is a carrier of an X-linked disorder, normal father. So their offsprings, the sons are affected, doctors are carriers. In this pedigree, the mother is normal, the father is affected. So all the daughters are carriers, but males are not affected. So both are an X-linked mode of inheritance. So the commonest disorder is a Duchenne muscular dystrophy, where child normal at birth shows a progressive proximal muscle weakness due to a mutation in the dystrophin gene, which affects the skeletal and cardiac muscle. So you confirm this mutation by doing mutation studies of the dystrophin gene. Last is your mitochondrial disorders. So mitochondrial disorders, like as there is a DNA in the nucleus, there is also a mitochondrial DNA, so which is different from the nuclear DNA. So normally what happens is the ovum contains the mitochondria, and the sperm also contains, but during fertilization the sperm, which the mitochondria, because it's in the body, gets lost, but only the mitochondria in the ovum is present. So any disorder, mitochondrial disorder, is always transmitted from the mother, and both the boy and the girl can be equally affected, and it's a progressive condition. Okay. So mitochondrial disorders, we see Leak's disease, Melas, and they usually present with poor muscle growth, loss of muscle coordination, visual, hearing, learning problems, and other system involvement. These disorders, how do you diagnose this genetic disorder? You cannot do any specific test. So finally, because the DNA is there both in the mitochondria and in the nucleus, you have to do a whole exome sequencing, which involves both the DNA to look for these mitochondrial disorders. Now, what are the other causes for genetic causes? So any child presenting from disorders in morphogenesis also has a genetic basis. So when there is a malformation due to a poor tissue formation, when there is a deformation due to an unusual force on a normal tissue, disruption due to breakdown of normal tissue, or a dysplasia, when there is an abnormal organization of cells, you get various malformations, but they also have a genetic basis. So these are the various malformations: cleft lip, palate, spina bifida, amniotic bands, heart defects. So once you have diagnosed, what do you do next? You have to give a counseling to the parents or explain to them. So genetic counseling plays a very important role in genetic disorders. Okay. So first, you call the parents, because they are pediatrics or small children. You have to explain to the parents and the family about the condition and how it will evolve, what will be the prognosis, the recurrence risk rates, and what will happen, what are the other comorbid conditions they can develop. So when you tell to them, they will definitely not feel good, they will feel very bad. So you have to give them a positive approach by talking more about your preventive genetics. So tell them how you can screen prenatally, antenatally for these genetic disorders, what are the tests you can do in the newborn, carrier screening or predictive screening to diagnose these disorders, so that they will be aware and may come back to you for the next pregnancy. So genetic counseling is not a one-type process. You have the patient has to be coming to you frequently, and it is an indirect form of counseling. So finally, to summarize, when a child comes with a genetic disorder, what are the tests you will ask for? So whenever you suspect a chromosomal disorder, first you go for a conventional karyotyping. So with this, you can make out most of your chromosomal disorders. So when you still feel it's a chromosomal and you are not able to diagnose by a conventional karyotyping, you can go for FISH or MLPA. So when you suspect microdeletion syndromes, FISH, MLPA, or a comparative genomic hybridization are the tests which you have to think of. So when you think of a single gene disorder or for Mendelian disorders, always go for a mutation analysis. When multiple genes are involved for a particular disorder, go for a microarray or for a targeted gene panel sequencing. When you do not know the cause, you have done all the tests, still you have not come to a diagnosis of what is a disorder, go for a whole exome or a clinical exome sequencing, which will give you a clue of what is the disorder. So these are the various tests you have to think of and ask only with your good history and clinical examination, and you come to a good diagnosis. So otherwise you will not know what test to ask for. So what are the treatment modalities available in genetics? Okay. So first, whenever there is a mutation, the only thing is replace a gene or go for a transplantation, hematopoietic stem cell or a bone marrow. When there is a mutation in the mRNA, try to silence the RNA. A mutant protein, enzyme replacement or a protein replacement. When there is a metabolic dysfunction, dietary therapy, pharmacological interventions. When only with the clinical phenotype you do not know how to manage the child, then go for the supportive management, pharmacological drugs or surgical management. And finally, for the family, you have to give a genetic counseling with a prenatal diagnosis and screening for further pregnancies. So I think I have broadly covered what is needed for you. Thank you, sir.